Get started. So welcome everyone today. And our topic and presenter today is Dr. Andrew Miller from Emory University. And the topic is one that's very relevant today. In particular, I think there's millions of people across America whose mental well-being is suddenly improved. So it's a good day for many in regards to the direction of our country. So that's a good thing. Well, yeah. So the topic today is inflammation and neuropsychiatric disease, and so this is part of our cross-disciplinary seminar series. And so this highlights inflammation and disease, and in a bigger picture, coming up with understanding, what the current novel treatment approaches are for targeting inflammation and disease. Today's session is co-hosted by the GW Neuroscience Institute, and this is part of the Biomedical Cross-disciplinary seminar series. And as I mentioned, so we're focused on inflammation and neuropsychiatric disease. And Dr. Andrew Miller is one of the pioneers in this field, the field of neuroimmunology. And I've been following Andy's work for years, back in my days when I was at Emory during my training. And Andy has been at Emory for most of his career. He's currently the William P. Timmie Professor of Psychiatry and Behavioral Sciences. He's the director of the Behavioral Immunology Program, and he's the vice chair for research. As I mentioned, his research group has been leading the field for decades with understanding for how the immune system modulates behavior, and coming up with new strategies to target the immune system for psychiatric disease. For example, his group is one of the first to conduct a clinical trial examining the efficacy of a cytokine antagonist for the treatment of resistant depression, treatment-resistant depression. But what's more impressive is at the cellular molecular level, in terms of understanding how the immune system modulates neurotransmitters and neural circuits. And his research group, from studying at the rodent level to non-human primates to humans, has sort of uncovered some of these important interactions with regards to how the immune system targets neurotransmitters and neural circuits to lead to conditions such as depression. And so that's his what he's going to be talking to us about today, which I'm really excited to hear about. Andy has over 200 publications in this area, and he's won numerous teaching and mentoring awards. And he has a long-standing principal investigator on multiple NIH grants, including training grants as well. So once again, thank you, Andy, for agreeing to give us a lecture on the emerging role of the immune system in depression and other psychiatric disorders. I think you were originally scheduled for last April. At that time, though, everything was sort of up in the air with COVID. And now we are, really feel like we're in a spot where we can see the light at the end of the tunnel, and vaccines are being distributed. So this is good. So I hope things are well for you in Atlanta. And again, I look forward to hearing your talk. If anyone wants to ask questions, put them in the chat box. And I hope towards the end we'll have 10 or 15 minutes for questions for Dr. Miller. So thank you again, Andy.
Well, thank you, Paul. It's a wonderful opportunity. Can everyone hear me? Is that volume okay?
Yes.
Yes, perfect. Okay, great. Well, it's a great opportunity for me to be here and share with you a little bit about what we're doing at Emory and how that sort of integrates with the larger literature in terms of the effects of inflammation on the brain. And our work has focused primarily on the impact of inflammation on the brain as it relates to depression. So we'll kind of start a little bit there, but then as indicated in this title, I think, Paul, you gave the actual title that I gave back April a year ago. And it's evolved, or I didn't know what it was, I forgot. But anyway, it extends a little bit beyond that, and then we'll sort of kind of spend some time digging into some of the mechanisms that are involved in how we understand inflammation affects the brain to lead to symptoms that map onto depression. And depending on time, I know I'm meeting with the students a little bit later this afternoon. I'll may have to cut it a little bit short if we want to leave time for questions. So we'll sort of play it by ear and see where we are. I'll keep an eye on the time. So I think most of you are aware that depression is a very serious illness, that it's quite common, affecting 25 million people in the United States. It's the 10th leading cause of death. And interestingly enough, because of how disabled people can become on the basis of depression, it is the leading cause of disability worldwide. And the biggest problem for those of us who actually treat depression is the fact that about a third of depressed patients really don't respond to conventional antidepressant therapies. And that includes not only medications as indicated here, but also to psychotherapies. And so this really underlines the need for us to kind of begin to think outside the box and come up with new conceptual frameworks and targets and be more specific and personalized in terms of our approach to patients, especially these individuals who fall into this category of treatment resistance. And that's sort of where inflammation comes into the picture. I think most of you are aware that inflammation is your body's natural response whenever there is infection with a pathogen, whenever there's tissue damage or destruction and wounding. But problems begin when there is either a very high degree of inflammation, or more commonly, inflammation becomes chronic, persistent, non-resolving, in which case it can do damage to many systems in the body, including the brain. And this notion that inflammation may be a root cause for many of the modern ills in our society, including heart disease and cancer, neurodegenerative disorders, and psychiatric disorders, as I'll be talking about today, really was recognized as one of the insights of the decade in science in their 2010 issue. So we many of the major illnesses, as I'm sure that is part of your seminar series, that we confront in our society, inflammation is playing a significant role. So what makes us think that there might be a link between inflammation and depression? There's quite an impressive amount of data in this area. Hundreds of papers have been published indicating that there are increases in inflammatory cytokines in the peripheral blood, cerebrospinal fluid of depressed patients. Meta-analyses of this literature indicate that interleukin-6 and TNF, or the tumor necrosis factor, are the most reliably elevated in this regard. There are increases in acute phase proteins, which are proteins that are produced by the liver in response to inflammatory cytokines and help contain the inflammatory response. And C-reactive protein is most reliable in this regard in terms of meta-analyses of the literature. And then there are increases in chemokines and which draw cells to the site of inflammation, and cellular adhesion molecules, which have the cells stick the site of inflammation. These two have been found to be elevated in depressed patients as a group compared to controls. And if you go into the brain and postmortem brain samples of depressed patients who've committed suicide, you see evidence of activation of inflammatory signaling pathways in brain parenchyma, as well as evidence of immune cell trafficking to the brain and activation of the immune cells of the brain and microglia. And what's interesting, relevant to our treatment-resistant depressed patients, is that there appears to be a special relationship between increases in inflammatory markers and treatment non-response, and especially as it relates to the conventional treatments for depression, which include the serotonin reuptake inhibitors and the serotonin norepinephrine reuptake inhibitors. And this is just some data from a recent paper that we published with just under 100 unmedicated depressed individuals, and we asked them, in your current episode of depression, how many treatment trials have you failed? And as you can see here in the purple dots, these are individuals who, the majority of the individuals really hadn't been treated at all during their current episode. But if you look at those who had failed 1, 2, or 3 or more treatment trials in their current episode, you can see this stepwise increase in TNF, as well as IL-6, the soluble receptor for TNF. And you see a similar pattern with C-reactive protein. Although the trend was significant, there were no significant differences among the groups, knowing that we don't know what's really going on with this group. And there's been a recent paper, a couple papers published by the UK group, showing that indeed C-reactive protein in treatment-resistant depressed patients is higher, significantly higher than patients who are treatment responsive. So depressed patients show increased inflammatory markers that are indicative of a chronic inflammatory response. Second major body of data that suggests that inflammation may play a role in the depression is the fact you can administer inflammatory cytokines. I'll be talking about interferon alpha, but other inflammatory stimuli, including endotoxin, typhoid vaccination, influenza vaccination, typically given to healthy volunteers. And this causes depressive symptoms. So you can administer inflammatory stimuli, and that leads to depressive symptoms, depression, and that has given us a lot of data regarding some of the neurotransmitters and the neurocircuits that are involved. And finally, there's data to suggest, this kind of completes the cause and effect loop, that you can inhibit inflammation and that will reduce depressive symptoms. And this has been seen primarily or most convincingly in autoimmune and inflammatory disorders, individuals treated with anti-cytokine therapies showing antidepressant responses. And then there's a much smaller literature in patients with depression who are otherwise medically healthy. This literature is very confounded by the study designs that are involved, as well as the drugs that have been used. So the jury is really still out whether anti-inflammatory drugs, certainly the ones that we are currently using, are going to be a meaningful treatment option for depressed patients, at least at this point. So based on this data, people kind of got the idea, well, it's all this data suggesting that depression is related to inflammation, and people were writing about depression as being an inflammatory disorder. And if there's anything that you take away from my presentation today, is that the answer to this question is absolutely not. And that's sort of the part about the inflammation, depression, and beyond, is that we understand now that inflammation really is only increased in a subgroup of depressed patients, about 30% of patients, depending on the sample. And this is relevant to a number of other factors that it can increase inflammation. Medically ill patients tend to have a little higher rate of inflammation in the context of depression. Patients who are treatment resistant, as I mentioned. So that 30% is really dependent on the sample. We also recognize that inflammation is also increased in a bunch of other disorders in association with behavioral changes. So not only mood disorders, but also anxiety disorders, PTSD and general anxiety disorder, OCD, panic, schizophrenia, neurodegenerative disorders, medical illnesses, all where there is an association between increased inflammation and symptoms that map on to symptoms that we typically see in depression. And so where we're at in terms of the state of the art is that the inflammation and its effects on behavior are really agnostic when it comes to diagnosis. This is a truly transdiagnostic phenomena, And if there is significant inflammation, it is going to interact with specific neurotransmitter systems and neurocircuits in the brain, ultimately leading to specific symptom profiles. And this really occurs across disorders. Now, before we get into the mechanisms of how inflammation is affecting the brain to change behavior, I'd like to jump into just a brief conversation about where does this chronic inflammation come from. And by and large, the most common cause of increased inflammation is obesity. As many of you know, this is a major problem in Western civilizations, especially the US. And fat cells grow very quickly. They outstrip their oxygen supply. They die. And so that death of the cells, the destruction of the cells, is considered a wound by the immune system. So macrophages will rush into the adipose tissue. And if you did biopsies in here, you'd see that this fatty tissue is loaded with macrophages, and they become little factories for cytokines and really can increase your chronic inflammatory response. As we get older, there are certain changes that occur in metabolism that promote an inflammatory diathesis. Same thing with early life stress seems to set early set points that predispose to inflammation, and coupled with chronic stress is associated with chronic inflammation. Dysbiosis, leakage of microbial products from the gut into the peripheral circulation can activate circulating immune cells and lead to chronic inflammation. As I mentioned, chronic illnesses and chronic infections. And we're actually just now jumping into this, but probably the most prominent in this is the sort of post-COVID syndromes that people are seeing that are characterized by many of the same sort of changes that we see in behavior that are associated with inflammation. And so many chronic infections lead to inflammation themselves, or having had a serious infection can lead to chronic inflammation. And of course, there are many things that we do in the clinics, surgery, radiation, chemotherapy, especially these are cancer patients, who we also study. I won't be talking about that today, but they also are characterized by very high levels of inflammation. So the tissue damage and destruction that comes about by virtue of these treatments and the immunotherapies as well can lead to chronic inflammation. So there are multiple sources, and if there are family members or patients, depending on what your interaction with other individuals are relevant to high inflammation, that you can see that there are many sources here that can contribute to behavioral changes. So what are the mechanisms by which inflammation affects the brain and ultimately behavior? And we know a great deal about this. Paul sort of mentioned that studies from cell culture, from laboratory animals, in humans. It could be an entire lecture in and of itself. The effects of inflammation on neurotransmitter metabolism and neuroplasticity. What we know is that inflammation leads to decreased synthesis and release of monoamines and increased reuptake, leading to decreased monoamine availability, which is one of the cornerstones of what we understand as part of the pathophysiology of depression. There are increases in glutamate, including increased release and decreased reuptake from astrocytes by virtue of the effects of inflammation on astrocytic function. This leads to extrasynaptic spillover of glutamate, which can bind to extrasynaptic NMDA receptors, which lead to decrease in growth factors, as well as it can be excitotoxic. And these decreases in growth factors and effects on neurogenesis can ultimately affect neuroplasticity. And taken all together, these effects on neurotransmitter metabolism and neuroplasticity, will ultimately then affect neurocircuits in the brain. And based on the many neuroimaging studies that have been done, which we'll look at a few of those as we move on in the lecture, the two major circuits that appear to be involved are those that are involved in anxiety, arousal, and alarm, and those that are involved in reward processing. Anxiety, arousal, and alarm include the involvement of the dorsal anterior cingulate cortex, insula, hippocampus, and amygdala. And those involved in reward processing involve basal ganglia, ventral striatal, nucleus accumbens, ventromedial prefrontal cortex, subgenual anterior cingulate cortex. And these effects on these reward-related circuits are associated with changes in motivational states, and ultimately leading to one of the core symptoms of depression, which is anhedonia. It's the loss of interest or pleasure, and this is one of the most disabling symptoms in anhedonia, and it's seen across psychiatric disorders also associated with suicide. And we're going to be focusing quite a bit on this particular circuit here this afternoon. So why these two circuits? So this is something that we've given some thought to, step back for a minute or two and say, well, if you were in the context of a sick or a wounded animal and there was an inflammatory response, there seems over evolutionary time to have been some form of a partnership developed between the immune system and the brain, such that effects of inflammatory cytokines on subcortical brain regions could lead to a sort of a withdrawal response, allowing the shunting of energy resources to fighting infection and wound healing and the symptoms that are involved, and away from exploratory activity. It's also relevant if you're a sick or a wounded animal that you're a vulnerable animal, vulnerable to attack. And so effects in cortical regions in the brain having to do with anxiety, arousal, and alarm, also including the amygdala, as I mentioned, serves a vigilance, hypervigilance function and protection against attack. And so these are the kinds of symptoms that we see that are related to inflammation. They have survival priorities, value in that area. And but you can imagine with chronic inflammation that these adaptive symptoms in the short run, if there's a chronic inflammation, this can bleed into things like anxiety, irritability, neuroticism, as well as depression, and even negative symptoms in syndromes like schizophrenia. And we're actively investigating this, the effects of inflammation on negative symptoms in schizophrenic patients at this point. So what are the effects of inflammation on some of the brain regions that are involved in reward processing? Much of our work started with looking at the effects of interferon alpha on patients. Interferon alpha causes depressive symptoms in 30 to 50% of patients, depending on the dose. This was quite a striking finding when it was one of the early immunotherapies that was used in cancer treatment. And the oncologist immediately noticed that their patients were becoming depressed. And interestingly, this occurred in the early 90s, and saw my first patient who was on interferon alpha, and it was quite striking to see how close there was a match between what we see in the clinic with depression and these syndromes that were being caused by these immunotherapies, in particular interferon alpha. So using interferon alpha, we wanted to sort of focus in on this reward circuitry, and using functional magnetic resonance imaging, we focused on the ventral striatum. And this is an area that's pivotal in reward processing. It includes the nucleus accumbens, the tag of the caudate, and the putamen. And to activate this brain region, we used a gambling task, a hedonic reward task. And in this task, the subjects are in the scanner. They see two cards face down. They're asked to pick a card. If they pick a red card, they win $1. If they pick a black card, they lose $1. We rig the game. Everybody wins 30, 40 bucks. They get paid to be in the scanner, and they're pretty happy about it. And if you then look at activation of these brain regions as indicated here, you can see that in the win versus lose condition, you get very nice activation in this ventral striatum region in this task. Now, if you then compare individuals who are being treated with interferon alpha for 4 weeks compared to control individuals, these are all individuals who had hepatitis C. So they're receiving interferon alpha for hepatitis C treatment. You can see the individuals who are receiving interferon alpha are showing significantly lower activation in the win versus lose condition in this reward task. And this is occurring right, left, and bilaterally in this particular reward-related brain region. And this decrease in ventral striatal activation maps directly onto behavior. So this is reduced motivation in these individuals, and you can see the lower the level of activation in the win versus lose condition in the ventral striatum, the higher the level of reduced motivation or anhedonia. And you can see that there's a clustering of these red dots who are interferon alpha treated patients who are having both low activation and high reduced motivation. This is a very interesting finding. Again, there's 4 weeks of interferon alpha, but interestingly enough, you can acutely administer inflammatory stimuli, endotoxin, typhoid vaccination. Actually, I should add influenza now. Vaccination has been added to this. So 4 different inflammatory stimuli all show exactly the same pattern with reduced ventral striatal activation in association with depressive symptoms, including reduced motivation. 4 different inflammatory stimuli, 4 different laboratories that have done this work. So this is a very reproducible finding, and I think one of the things that's always important as we consider our work and the reproducibility of our work. And of course, the NIMH has kind of gone gaga about some of this reproducibility, but it is important that findings be replicated across laboratories and are consistent, and this is one of them. So in terms of these effects that we see in the ventral striatum, what might be the neurotransmitter systems that are involved? And the 2 major neurotransmitter systems that play a role in terms of reward circuitry in ventral striatum and the accumbens is dopamine from ventral tegmental area, as well as the substantia nigra, and glutamate fibers projecting from the prefrontal cortex. So we'll talk a little bit about the effects of inflammation on dopamine and glutamate. So start with dopamine. In order to study this, as Paul mentioned, we've done studies in non-human primates, rhesus monkeys, and this is the work of Jennifer Felger, where she developed as a graduate student a rhesus monkey model of cytokine-induced depression. We noticed very early on that monkeys started to assume this sort of huddling behavior with eyes cast down and head lower than shoulders. The animal looks depressed, and we sort of had puzzled by this behavior and went into the literature to figure out, well, where else had this been observed? And lo and behold, this had been first described by Harlow in the early 70s in animals that had been chronically treated with reserpine. And for those of you who are not familiar with reserpine, it depletes monoamines and is associated with the development of depressive-like behavior in both animals and humans, and was one of the cornerstones of the monoamine hypothesis of depression. So this told us very early on that interferon alpha was influencing monoamine neurotransmitter systems, including dopamine. So in order to study the effects of interferon alpha and dopamine, especially in this ventral striatal region, we did in vivo microdialysis. So a probe was put into the brain of awake, alert animals, and this is just north of this ventral striatal region in these animals. And we sampled using the probe. You can both sample extracellular fluid in this region as well as put in various drugs, and potassium and amphetamine would stimulate dopamine release. And what we found under resting conditions was interferon alpha after 4 weeks of treatment in these animals led to rather dramatic reductions in dopamine, as well as the major metabolite of dopamine, homovinylic acid. And then when we went to stimulate dopamine with potassium or amphetamine, we found these very marked reductions in the stimulation and release of dopamine after treatment with interferon alpha. So in this same brain region where we saw reduced activation in this hedonic reward task in humans, we're also seeing this reduction in dopamine availability both at baseline and following stimulated release. And what's interesting here is when we went to map this onto behavior, we found that there were some interesting differences here. And these are relevant in terms of the effects and more nuanced effects of inflammation on motivation. If we just put sugar pellets in a feeder for the monkeys to enjoy or not, we found that there was really no effect of interferon alpha, so the number of pellets consumed really didn't change as a function of interferon alpha. But if the monkeys had to work for the pellet, so if we put the sugar pellet into a puzzle feeder and the monkey had to use its finger to kind of move the pellet along through these different columns and tubes here, and then finally get the pellet at the end, we noticed that interferon alpha treatment was associated with a significant reduction in pellet consumption, and this is a reduction in effort-based motivation. So if you have to work for it, not going to do it. If you just put it out there in front of people or in front of the animals, they will consume. So there's not a reduction in the ability, the capacity to experience pleasure. It's just that you're not going to work for it. And this, interestingly, was correlated with the dopamine response that I showed you before, a dopamine release. So the lower the dopamine the release, the lower the pellets consumed, obviously small numbers because these are rhesus animal studies. Back to our issue of reproducibility. So is this just something we see in monkeys? No, it's also seen in rodents. This is the work by John Solomon at the University of Connecticut. Doing again in vivo microdialysis and administering interleukin-6 intraperitoneally. And these are different probe placements here of different probes within different regions of the nucleus accumbens. And what he saw within a very short time after administration of interleukin-6 are rather dramatic reductions in extracellular dopamine no matter where he placed the probe. And what was again interesting in these experiments is that this decrease in dopamine that you saw following IL-6 was associated with a decreased effort-based motivation, in this case working for a chocolate pellet versus eating the pellets if just presented to the animals without having to work for them. And interestingly enough, this could be reversed by methylphenidate, amphetamine. A long story that I don't have time to get into, but actually Paul helped us with some of these studies. There's data to suggest that some of the effects of inflammation may be a result of effects of inflammation on the synthesis of dopamine, and this involves effects of inflammation on the enzyme tetrahydrobiopterin, or BH4. And what we found was that there were reductions in BH4 related to inflammation, and these were associated with decreases in the activity of enzymes of tyrosine hydroxylase and phenylalanine hydroxylase, which are all involved in the synthesis of dopamine. So Jennifer had the idea, Dr. Felger, why don't we jump over all these synthetic steps and just put L-DOPA into the dialysis and by a reverse microdialysis, and you can see that if you put in L-DOPA, you completely reverse the effects of interferon alpha on dopamine released by amphetamine. So these changes can be reversed if you provide the immediate precursor to dopamine in these animals in these in vivo microdialysis situation. Now it's incumbent upon us to sort of figure out, well, what exactly is going on in the neurons themselves in terms of the synthesis. And in order to do this, we just mentioned briefly, we've moved into using induced pluripotent stem cell technology, which is really an amazing technology. You can grow various human brain organoids, mini brains, and you can grow up dopamine midbrain organoids, which we've done. And here you can see the organoids at day 84 with very nice staining of the dopaminergic neurons and the tyrosine hydroxylase, rate-limiting enzyme for dopamine, staining in red in the axonal projections. You get a very nice culture here. And if you treat those organoids at day 84 with interleukin-6, for example, for 24 hours, and then measure the release of dopamine here, We're looking at HPLC, and this is the standard to tell us where dopamine is. It's the control cultures get a nice dopamine release. And look, 24 hours of interleukin-6 almost completely eliminates dopamine availability or release in these organoids. And so now we have a platform where we can understand the mechanisms by which inflammation is affecting dopamine, as well as a platform for drug discovery. So we're very excited about this developing work. So what about the other major neurotransmitter that's playing a role in reward processing, glutamate? And there's quite a story on the effects of inflammation on glutamate metabolism, a number of effects that inflammation has on glutamate metabolism. It can affect the excitatory amino acid transporters, which are responsible for removing glutamate from the synapse. Increased inflammation actually leads to reverse efflux, so through the transporter. So not only is it not taking the glutamate out of the synapse, it's actually pushing more glutamate back into the synapse. There's also activation of the kynurenine pathway. We can talk about that later this afternoon. I'm not going to be talking about that today or in this lecture. But activation of the kynurenine pathway by inflammation leads to kynurenine going into the brain, and that is converted in microglia to quinolinic acid, and quinolinic acid can stimulate astrocytes in this tripartite synapse, glutamate, presynaptic, postsynaptic neuron, and then the astrocytes, microglia involved as well, secreting quinolinic acid to lead to increased glutamate, decreased glutamate reuptake and increased glutamate release from astrocytes. And taken together, this can lead to a buildup of glutamate in the synapse, which then can, as I mentioned, bind to extrasynaptic glutamate receptors, which can lead to decreased growth factors and excitotoxicity. And also this spillover of glutamate into the extrasynaptic space can go over here and stimulate an adjacent neuron, and this can lead to chaotic neuronal signaling and reduce the precision of and coherence of neuronal signaling in clusters of nearby neurons. And we'll talk about that in just a minute. So in order to measure glutamate in the brain in the context of inflammation, we've been using magnetic resonance spectroscopy and looking in particular areas involving the basal ganglia and the dorsal anterior cingulate cortex. It's just a spectrum from a representative brain here, and here's the glutamate peak. And so we can measure glutamate, and as I said, we've been focused on the basal ganglia, at least for this particular talk. And you can see after administration of interferon alpha, again, we started with that inflammatory stimulus, very controlled exposure to an inflammation that leads to very clear-cut behavioral changes. You can see an increase in glutamate in the left basal ganglia, and that increased glutamate in interferon alpha treated patients is associated with reduced motivation. Interesting that this is also seen in patients with major depression. So these are individuals where we're looking at endogenous increases in inflammation. Low, medium, or high C-reactive protein is our index of inflammation. You can see a stepwise increase in glutamate in the basal ganglia, and there's also a linear association as well between inflammation as measured by CRP and glutamate. And this increased glutamate is then in turn mapped onto behavioral symptoms, including anhedonia and psychomotor speed, as measured in a finger tapping task or reaction time or a digit symbol task. These are all the higher the level of glutamate, the poorer the performance on psychomotor tasks, and the higher the anhedonia, again with higher glutamate in these left basal ganglia region. So Ibrahim had the idea, and this is something that we've gotten more into, is the idea that not all inflammation is created equally. So there are people who have high inflammation and high glutamate, and individuals who have low inflammation, low glutamate, sort of beginning to parse out groups of individuals within depression. And so Ibrahim did some clustering algorithms and came out with two groups, a high CRP glutamate group and a low CRP inflammation glutamate group. And what was interesting about these groups is that if you go in and you measure using, and this is multimodal neuroimaging, so now you're combining fMRI with MRS, and the fMRI allows you to look at the oscillatory activity of neurons through activation. And if that oscillatory activity is very synchronized, you have high homogeneity. And if that becomes desynchronized and there's chaotic signaling, you start to see that this regional homogeneity will decrease. And so what they saw in individuals with high CRP and high glutamate was this decrease in coherence of firing and regional homogeneity. And you could actually then compare these two groups and look to see if there are regional homogeneity differences across the entire brain, comparing those with low CRP glutamate to high CRP glutamate. And you can see there are a number of brain regions, actually 41 brain regions that subserve networks. And one of those networks being a network within the reward circuitry, and decreased regional homogeneity, coherence and firing was associated with decreased connectivity within this network, which in turn was associated with increased anhedonia. And this, you can see just the whole brain. In red is tight connections, increased connections, correlations between these different brain regions. And you can see if you move into a high CRP glutamate condition, you're losing your coherence of firing, you're losing your connectivity among these multiple brain regions. So basically, this effects of inflammation on both glutamate and dopamine converge in the striatum to lead to alterations in the signaling in these brain regions. So this is in the median spiny neurons in the striatum, where it's playing a critical role in reward processing, and dopamine influencing the firing of these neurons, and their inflammation affecting not only the dopamine, but also the glutamate that's involved in what the output from the striatum will be, which will ultimately determine how you respond to a given rewarding stimulus. Now, what's interesting about the striatum and this convergence of the effects of inflammation on these neurotransmitter systems that are also converging in this brain region in the median spiny neurons and the output of the striatum is the fact that if you look at what's going on in the immune system in this brain regions, and these are post-mortem studies from the rhesus monkeys that have been treated with interferon alpha. These are control animals. This is an IBA1 staining in green here, and you can see that in these in the globus pallidus, another region that's involved in reward processing, you see activation of the microglia. And if you look in the striatum itself, you see that around the blood vessels, there's increased staining of macrophages and the meninges in these brain regions. So what appears to be in the context of interferon alpha is that immune cells are trafficking to this area of the brain where they're uniquely poised to release cytokines. And what's been a really cool finding from the Rousseau group at Mount Sinai is this is also a region that in the context of chronic stress and inflammation, that there is permeability in the blood-brain barrier to inflammatory cytokines like interleukin-6, and it appears to be specific for these ventral striatum nucleus accumbens region. And so this is from a study that they did. They exposed male mice to 10 days of a bully mouse, which the bully mouse not only intimidates the animal, but wounds the animal. So it's a pretty intense stress. And after the 10 days, you end up with stress-sensitive animals that show depressive-like behavior, and then there's stress-resilient animals that don't seem to be affected much at all. And this staining in red here, excuse me, the staining in red here is the blood-brain barrier, and what they did is they injected these animals with a biotinylated labeled IL-6 in green, and you can see in the control animals, intact blood-brain barrier, no IL-6 gets into the brain. If you go into the stress-resilient area, and again, we're talking about this nucleus accumbens area, nice intact blood-brain barrier, no IL-6 in the brain. But look what happens in the stress-sensitive area. The blood-brain barrier looks like crap, and IL-6 is pouring into the brain. And interestingly, they looked throughout the brain, and the only difference that they saw between the stress-sensitive and stress-resilient animals was in this area, the nucleus accumbens, the ventral striatum. And interestingly, they've also seen this in postmortem samples from depressed patients, where there is a decrease in blood-brain barrier integrity in this brain region, and it appears to be associated with the effects of inflammation on a protein Claudin-5, which is involved in blood-brain barrier integrity. And Claudin-5 is reduced through activation of T and NF-kappa B signaling pathways. And that appears to be the mechanism, and also involves some histones deacetylation and epigenetic changes. So what about the impact of this inflammation on reward circuitry in humans? Is this kind of a translational target that we can use? And in order to study this, we've used resting state functional connectivity. So now we're looking in patients with major depression, and we're asking the questions, is these effects that we see when we administer various inflammatory stimuli and when we see effects on dopamine and glutamate, does this affect reward circuitry in patients with depression and ultimately contribute to anhedonia? And to study this, we use resting state functional connectivity. So here you're looking at different brain regions and whether their activity is in sync. And if they're in sync, you're looking at different nodes of activity, and then the relationship among these nodes lead to development of notions of circuits, and these circuits then map onto behavior. We're particularly interested in the circuit that relates to the ventral striatum, and you should have good reason to believe that why we're interested in the ventral striatum, because there's this convergence of cells going into that area, the permeability of the blood-brain barrier, the changes we see in the neurotransmitter systems there, and the changes we see in the activation if we directly activate these circuits. But what about the connectivity of this circuit to the ventral medial prefrontal cortex? So it's really the heart of the reward circuitry in the brain. Do you see changes in that connectivity as a function of increased inflammation? And so in order to do this, we're doing the resting state fMRI, and we used the C-reactive protein as our marker of endogenous inflammation. And thanks to the American Heart Association and the Centers for Disease Control and Prevention, they've kind of helped us with a low, medium, and high level of inflammation. A CRP can be done in any clinic or hospital throughout the United States and pretty much throughout the world. So you can immediately know the level of inflammation in a patient. And these were developed based on a risk for cardiovascular disease and metabolic disorders. But you can see this high CRP in this group here maps on very nicely with a composite of measures of inflammatory, individual inflammatory cytokines. Here you can see the individual cytokines themselves. It maps not only in the plasma cytokines, but it also does the composite, maps onto this plasma CRP increases above 3, maps onto a composite in the cerebrospinal fluid, so in the brain. So your plasma CRP is giving an idea of what's going on in the brain relative to inflammation, and you can see the individual cytokines, but again, this is the composite. You see these marked differences between people with low and high inflammation. So what we wanted to know is, as your CRP, as your inflammation goes up, what happens to the connectivity between the ventral striatum? And we did a whole brain analysis, but lo and behold, we were pleased to see the finding, not surprised, but the biggest change in connectivity between ventral striatum and anywhere else in the brain was between the ventral striatum and the ventral medial prefrontal cortex, which was that heart of that reward circuitry, and the change was in a negative direction. So what you're seeing is a decrease in connectivity between ventral striatum and ventral medial prefrontal cortex as inflammation goes up. Here you can see it graphed, CRP goes up, connectivity between these regions goes down. And that decreased connectivity was correlated with increased anhedonia or decreased motivation. And in dorsal regions of the striatum, this was associated with decreases in psychomotor activity. Now, Jennifer was wanting to kind of do the same thing she did with the monkeys to see, well, can we reverse this decreased connectivity? This has been an area that is a very active area of investigation in our lab. So here again, we're doing resting state functional connectivity. We're looking at depressed patients. Here are patients with high CRP. You see they have decreased connectivity in baseline. Connectivity again between ventral striatum and ventral medial prefrontal cortex, which I showed you in the previous study. And so Jennifer wanted to see if she could reverse it by giving L-DOPA, but rather than giving it in the brain as we gave it in the monkeys, we gave it by mouth in the form of Cinemat, which is given in Parkinson's disease. And what you can see was treatment with L-DOPA not only returns connectivity to normal, but also you see this overshoot suggesting that there may be supersensitivity in these pathways related to dopamine. This tells us is that patients with high inflammation may preferentially respond to dopaminergic medications. Dopamine is clearly a target, and there are a number of drugs that we have available to us that we can use. I mentioned that the stimulants were able to reverse the changes that we saw in the rodents. And currently we're doing a study where we're comparing bupropion with an SSRI and escitalopram, a drug that's targeting serotonin, which I showed you before, tend not to respond well when there's high inflammation. So we're taking all high inflammation patients and we're randomizing them to bupropion versus escitalopram and looking to see if bupropion is able to reverse changes in functional connectivity within reward circuits and objective measures of reward effort-based behavior and ultimately depression, ultimately allowing us to then use inflammation, measures of inflammation like CRP to sort of parse out and tailor treatment of antidepressants for patients with depression. And the question is glutamate a target too? And finally, let me just talk a little bit about some of our work with infliximab that Paul mentioned and give us a little bit of time for questions. So we have looked at whether blocking inflammation can reverse some of these alterations that we see that inflammation has on motivation. So asking the question, is inflammation a translational target? To do this, we used a monoclonal antibody to TNF called infliximab. And these are biologic drugs. They're quite potent. They have very few off-target effects because they're so selective, just targeting TNF. Limited drug-drug interactions. And so we did a 12-week randomized controlled trial in patients with treatment-resistant depressions. They failed multiple trials of antidepressants. And this was the design, 60 patients, 30 in each group, 30 in placebo. Infliximab, we gave them 3 infusions of infliximab, which is the standard sort of induction protocol for treatment of inflammatory bowel disease. And then we did multiple measurements of behavior across time. This just gives you a little bit of sense of what the sample looked like. So we were recruiting solely for treatment resistance, not for inflammation, but you can see these treatment resistant individuals are obese and they have very high inflammation levels. The CRP's up in the 6 range, and 50%, almost 50% of our patients had high inflammation according to CDC. That's the CRP greater than 3. And if you go through the math of how many people are depressed and how many people are treatment resistant and how many people have high inflammation, you end up with 5 million people in the United States who are depressed, treatment resistant, and likely have high inflammation. That's a lot of people. So this is an important population. Just give you the numbers in rheumatoid arthritis and inflammatory bowel disease as a comparator. These were the results. I almost killed myself when I saw them, which is not good for a psychiatrist to say that, but it certainly felt that way. Absolutely no difference between infliximab and placebo. But this trial was done when we were living the dream that everybody with depression had, which I explained as the field has matured, is clearly not the case. So we asked the question, well, does it matter your level of inflammation when you start the study as to whether or not you respond? And the answer was yes, that your response to treatment over time was definitely dependent on your baseline CRP. The sweet spot was a CRP greater than 5, so that individuals with high inflammation greater than 5 had almost a doubling response to infliximab compared to placebo. But look what happens in individuals with lower levels of inflammation. They actually did worse on infliximab, suggesting that blocking inflammation is not always a good thing if you don't have any inflammation to start with. What are the symptoms that got better? These are the symptoms from the Hamilton Depression Rating Scale. This is baseline and you're going to week 12, which was the end of the study. And if you're going in this direction, you're getting better. That's a decrease in the symptom. And working activities is anhedonia. This is retardation, is psychomotor retardations of motivation and motor activity, and anxiety. So mapping exactly onto the symptoms that we understand that inflammation affects through its effects on neurotransmitters and neurocircuits in the brain. And interestingly, there have been 2 other studies that have used anti-cytokine therapies since, and in both of those studies, anhedonia was a major treatment target. The treatments were most effective on those symptoms. I don't have time to go into this. I'll just briefly mention that the story gets even more complicated when you start to get into metabolism. Maybe we can talk more about this this afternoon, but suffice it to say that response to infliximab and the relationship of inflammation and anhedonia is tightly related to not only inflammation, but also metabolism. And it's the combination of the effects of inflammation as well as its associated effects on metabolism, including glycolysis and lipid metabolism, that appears to be the magic bullet in terms of the effects of inflammation on the brain. I really don't have time to go through that work at this point. So in summary, we can just look at it a little bit here. Activated immune cells are quite a bit of an energy drain on the body in general. And in the context of activation, we think that energy drain is, or that energy drag on the system is communicated to the brain in this area of the striatum, where the cytokines can enter and influence glutamate metabolism and dopamine metabolism, ultimately influencing neurocircuits in the brain and having effects on anhedonia that really are about effort expenditure and some other nuanced effects of, that are related to reward processing without affecting capacity to experience reward. And so summary just tells us that we've learned a lot about this, that we can now have targets for treatment that involve dopamine, glutamate, and metabolism, and inflammation. We can identify the patients, and many of us think that this is really our first, it can be one of the first forays into really doing precision medicine by identifying these patients, knowing the pathophysiology, knowing the targets, and thereby tailoring the treatment. So let me stop there. I know it's 1 o'clock, but so be it. And I'm happy to take any questions, whatever time there is. And we can talk again later this afternoon. I think the students from 2 to 3 or something like that, Paul. Is that
Yeah, that's right. Well, thank you, Andy, for that outstanding talk and really describing a really impressive body of work that you've accomplished over the past couple decades in that short amount of time. So thank you again. And if you don't mind, if we could take a couple questions.
That's fine by me.
And then we have one in the chat box right now. And this is from Golem Kandagar out of the UK.
How to go and get on this?
It is.
Are you in the States? No, you can't be.
6 p.m. in the UK, I think.
We wouldn't let you in the United States.
That's right.
Go
well,
for it.
Yeah, so his question in the chat box, great talk. Thank you, Andy. So this is a bigger picture question. What do you see as the most promising immunological therapeutic target for depression, and which patients may benefit from these therapies, given, as you say, inflammation is not specific to depression?
So in terms of the immunologic target, and I think Golem knows probably as well as anybody, we've had a real problem in terms of the treatment trials that have been conducted, and I didn't get into that, and that's kind of a talk for another day. But by and large, the treatment trials in depression using anti-inflammatory agents have used drugs like aspirin or celecoxib, which is a COX-2 inhibitor, and minocycline, which is stabilizes microglia. These trials have been conducted in individuals that are a heterogeneous population of depressed patients. And so we're really not homing in on those individuals with high inflammation in these trials. And not only that, we're not comparing people with high inflammation versus low inflammation. So if you think your drug is working on inflammation, then it shouldn't work in people with high inflammation. It should only work in people with, it shouldn't work in people with low inflammation, only should work in people with high inflammation. So no trials like that have been done. So we need to do a lot better in terms of our trials. And then we need to, obviously, as Golem is referring to, is we need to do better with our immunologic targets. And so we've started to dive into this, as I'm sure his group has is doing the same, or I know they're doing similar work in the UK. And we're trying to dig in a little deeper to find out what's going on immunologically. And some of these issues around immunometabolism that I didn't get to go into, I think are going to be interesting potential targets, as well as some of the inflammatory signaling pathways that are going to be identified. And this really is going to have to involve doing careful studies in very well characterized patients that are not on medications, that do not have a variety of medical illnesses, including autoimmune or other inflammatory disorders, and doing things like single-cell RNA-seq and looking within the immune cells themselves and asking the question, which immune cells, under what conditions is that associated with increased inflammation? And then when you use an anti-inflammatory treatment, when behavior moves, what kinds of immune molecules move, what pathways move. And so doing that kind of careful work, I think we're going to be able to begin to parse out what are the best immunologic targets. Right now, we're just kind of throwing darts at the wall, and we really don't know what the pathways are. And all of the treatments that we've used to this point are very crude. So that would be my response. There's much work to be done, and I don't think we have the answer to the question is what would be the best target.
Okay, thank you very much. Does anyone else have a question for Dr.
Valeria? So here's one from Valeria Mondelli. Again from the UK, asking about these trafficking that Jennifer will never publish, hasn't yet published. I'm torturing her to publish this paper on the cells trafficking to the brain. Is interferon alpha administered peripherally? Yes. So this is just like the cytokine-induced depression model with the rhesus monkeys is exactly the same as what you see with what's done with humans. So it's administered subcutaneously, peripherally. And do you see a correlation between increase in cytokines and the microglial activation in the same animals? We haven't looked at it yet. Good question. We should do that. So thank you, Valeria. I'll let Jennifer know that she should add that to her list of things to do. She's been avoiding the paper because she's more interested in the L-DOPA stuff at this point. So. Prednisone and depression has been linked. Can you comment? Yeah, so prednisone, that's, I get that on reviews all the time, say, why don't you just give prednisone? Aren't steroids a great anti-inflammatory drug? Problem is that glucocorticoids have effects on multiple aspects of brain function. And prednisone is an antidepressant in and of itself. So you can just give prednisone to people who are not inflamed necessarily, or I guess they are inflamed if they're getting it. But if you give prednisone to people, they tend to get hypomanic. And if you can give prednisone and other glucocorticoids to people under control conditions, and they tend to show hypomania over depression. There are a small subset of people that when you give them prednisone or other glucocorticoids, they will get depressed. But by far and away, the more common reaction is hypomania if they have a reaction at all. So because of the complications that glucocorticoids have based on their direct effects on neurons and other cell types and signaling pathways that are unrelated to inflammation, it's a drug that has multiple off-target effects, and not a good drug to potentially use to try to understand more about the specific pathways by which inflammation is affecting behavior. Sex effects in the studies. Yes, there are. We have not published on those, but there is data on sex effects. That's actually an interesting something that we're actually looking at in the iPSC cells at this time, so we can really home in on whether this is something at a genetic level or it's related to hormones. But there's a study that was done by Naomi Eisenberger and their group, and they gave endotoxin to men and women, healthy volunteers, and they found that despite the fact that both men and women had a similar cytokine response to endotoxin, that the women showed a stronger correlation between the level of cytokine response and the effects on ventral striatal activation. So there were some sex effects there, which are, I think, quite intriguing, and it looks as if it's happening in terms of the interaction between the effects of inflammatory cytokines on these specific brain regions that I was talking about today, and likely the specific neurotransmitter systems, which is why we're interested in looking at direct effects on these dopaminergic neurons in male versus female iPSCs.
Yeah, Andy, there's a question here that beyond that in the chat that I just will chime in here, that I think it's many people ask, and I think you've heard this question before, the chicken or the egg question, and the idea that there's a particular trigger, whether it's obesity, chronic stress, that can lead to this persistent systemic inflammation that then triggers depressive symptoms, or can you have depression first, that I guess then perpetuates the inflammation and leads to behavioral changes that then goes into this vicious cycle with maybe overeating and things like that, alterations in behavior that are risk factors.
Yeah, I think that if you depends on how you want to read the literature. I mean, clearly we all understand that these things are interconnected, and once a particular pathway gets started, there's a number of feed forward cascades. But if you look at the literature, the inflammation, a number of studies that have shown that inflammation, if you have inflammation at time point 1, you have depression at time point 2, let's say. Okay, so they've done these longitudinal studies, and the data tends to show that the inflammation comes first, depression comes second. It's not that you have depression first and inflammation later. So by and large, and the Golem Kondaker, I think, did a recent paper on this, or one of the UK people did a meta-analysis on all these papers. And by and large, that's the way it looks, although there are studies that show the opposite. In terms of the obesity thing, we think that the obesity thing is very interesting, because a lot of these things, we're talking about pathology, but we think these pathways are working in everyday life, so that people who are obese and have chronic inflammation, that inflammation is affecting people's decision-making processes, such that they prefer to sit on the couch and eat an unshelled peanut and they'll enjoy the peanuts, but they just don't work for them. We've known for years that if you put a bowl of shelled versus unshelled peanuts, somebody who is obese will eat the unshelled but won't eat the shelled peanuts. Yeah. Always, people can never figure out, well, they're just too lazy to do that. No, there are certain processes that go on in the brain that are occurring at subclinical levels that are affecting our decision-making processes. And so those things could then lead to a greater obesity, higher levels of inflammation, and you're sort of having that feed-forward cascade. And then it may ultimately bleed into depression, and that depression may be contributed to by psychological isolation because of being embarrassed about your weight gain, and then you get all sorts of other things that enter into the equation. But many of these things start out with physiologic processes that are adaptive. They're built into our system. We're not used to being obese. And then all of a sudden being a little bit overweight, and you got a little bit of inflammation going. And then now all of a sudden that's affecting how you're making decisions. Maybe I won't go to the gym today. I don't want to expend. I know it'd be great if I got there. And many of the treatments like behavioral activation will work in somebody who has increased inflammation because they have the capacity to experience pleasure. So if you can get them to go out and interact in a situation where they might achieve some enjoyment, they'll actually enjoy themselves. And then you can feed on that, and then potentially that could, resolve their depression. So these are interesting nuances that have therapeutic implications as you think them through. And we're just at the tip of the iceberg with this. We obviously started with worst case scenario. Somebody's horribly depressed and can't get better, and sort of working our way back into decisions that are made in everyday life that can be influenced by inflammation. And then those decisions may ultimately could be contributing to disease.
Okay, thank you very much, Andy. And I think we'll leave it there. It's 1:15. Thanks for taking those extra questions. Going a little overtime, and I appreciate it. And thank you all for attending this session today.
Thank you all for coming. I really appreciate it, and I especially appreciate those who are dialing in or zooming in from overseas. Yeah. It's great to see some of my buddies.
Yeah. All right. Thank you again, Andy, and we'll be in touch with the student session.
All right. That's at
2, I believe. Yeah, I'll send you that information now.
Fabulous. Okay. All right. Thanks, y'all.
Thanks. All right. Bye-bye.
Bye-bye.